Talking about the clinical correlation, let's first discuss the Erb's point. So what is the Erb's point? As you can see here, this is the Erb's point. So Erb's point is the region of the upper trunk of the brachial plexus where 6 nerves meet. Okay. So which are the 6 nerves? As you can see here, we have the roots of the 5th and the 6th cervical roots which join to form the upper trunk, from which 2 nerves arise, the suprascapular nerve and the nerve to subclavius, and also the upper trunk divides to form the anterior and the posterior divisions. So this is the Erb's point. It's a meeting point of 6 nerves. In this diagram, let's locate the Erb's point. So this will be the Erb's point where the C5, C6 roots meet and the upper trunk divides to form the anterior and posterior division, along with the emergence of 2 nerves, the suprascapular and the nerve to subclavius. So injury to the Erb's point can lead to a particular type of deformity known as the policeman's tip hand or the waiter's tip deformity. What is it? It's called the and this sort of deformity is formed when there is upper plexus injury. Which leads to a lesion known as Erb's paralysis. Now let's see how can this injury happen. So injury of the upper brachial plexus leading to excessive increase in the angle between the head and the shoulder can occur due to fall from a height, as is seen in this figure, or it can due to traction of arm and hyperextension of the neck, which usually happens during forceps delivery. So injury of the upper brachial plexus, it can lead to excessive increase in the angle between the head and the shoulder, and it can either occur due to fall from a height and landing on the shoulder, or it can occur due to traction of arm and hyperextension of the neck, which is usually seen during forceps delivery. And this is the policeman's tip deformity, also known as the waiter's tip position or the porter's tip deformity. Now, apart from the upper plexus injury, there can also be lower plexus injury, right? So, lower plexus injury usually leading to the excessive increase in the angle between the trunk and the shoulder can occur due to sudden upward pull of the arm, as is seen in this figure, or it can occur due to the arm being pulled during the delivery. So this leads to excessive increase in the angle between the trunk and the shoulder. The first one was between the neck and the shoulder. This is between trunk and the shoulder. So the first we saw the upper plexus injury, and second we saw lower plexus injury. So the injury of the lower plexus leads to a particular deformity known as the Klumpke's paralysis. What is it? Klumpke's paralysis. So, before we move on to the difference between Erb's paralysis and Klumpke's paralysis, let's talk about some basic features that are seen in Erb's paralysis or the policeman's tip hand deformity. So, as you can see in this figure, the arm is adducted. So, the first feature is adduction of the arm. So, let's list out the features. The first feature is adduction of arm. Why does this happen? It is due to the paralysis of deltoid. Next feature we can see here is a medial rotation of the arm. So next we have medial rotation of the arm. This occurs due to the paralysis of the supraspinatus, infraspinatus and the teres minor. Next, the elbow here is extended. So there will be extension of the elbow, which occurs due to the paralysis of biceps brachii. Next, we can see that the forearm is pronated, and this also occurs due to the paralysis of biceps brachii. Along with that, there will be loss of sensation. Even though it's minimal, there will be loss of sensation along the outer aspect of the arm due to the involvement of the C6 spinal nerve root. Okay, so what are the features that we see? Adduction. The arm will be adducted with the medial rotation. Elbow will be extended because biceps, which is responsible for flexion of elbow, is paralyzed. So there will be extension of elbow along with pronation of forearm. Also there will be loss of sensation along the outer aspect of the arm. Why? Because the C6 spinal root is involved. So paralysis, just summarizing it. So why is it caused? It's an upper plexus injury which is caused due to increase in the angle between the head and the shoulder, as occurs during either it can occur due to landing on shoulder or fall from a height, or it can occur due to forceps delivery. Then there is traction of the arm which occurs during childbirth. So there is a classical typical deformity that happens, which is the policeman's tip deformity, or the policeman's tip hand, or the potter's tip hand, or the waiter's tip hand, and it is due to the involvement of the upper trunk. Which trunk is involved? The upper trunk. We know which is the Erb's point. So any injury to that point, that is the Erb's point, can lead to Erb's paralysis. So which trunk or which root will be involved? C5, C6 roots, also the upper trunk. So here in this deformity, the arm, it hangs by the side, it will be adducted, medially rotated, and the forearm is extended and it's pronated. Due to the paralysis of which muscles? We have already listed it down here. So apart from the Erb's paralysis, we also have Klumpke's paralysis, which occurs due to lower plexus injury. Now let's discuss the features of both Klumpke's and Erb's paralysis. So which are the nerve roots involved in Erb's paralysis? We know Erb's paralysis is a upper plexus injury. Therefore, the nerve roots involved is C5 and C6 because Erb's point is located on the upper trunk. So, but in Klumpke's paralysis, the nerve roots involved are C8 and T1. Muscles that are paralyzed, there will be deltoid, supraspinatus, infraspinatus, and so the teres minor, along with biceps brachii, brachialis, brachioradialis, supinata, extensor carpi, radialis longus. In Klumpke's paralysis, all the intrinsic muscles of the hand will be paralyzed due to the involvement of the nerves which are supplying the intrinsic muscles. Now, position of the upper limb, the typical feature is policeman's tip hand position. In Klumpke's paralysis, there will be claw hand. So, we will be learning about the claw hand when we talk about each nerve in detail. Then, is there sensory loss? Yes, we did discuss there will be sensory loss along the outer aspect of the arm because C6 root is involved. In Klumpke's paralysis, along the medial border of the forearm and the hand, there will be loss of sensation. Is any autonomic signs present? In Erb's paralysis, there is no autonomic signs, whereas in Klumpke's paralysis, we have the Horner syndrome. So Horner syndrome is also having a set of characteristics like anhidrosis, ptosis, etc., which will be dealt later. So this is all about Erb's paralysis and slump case paralysis and the clinical correlation of brachial plexus. So when you write about the brachial plexus as an answer in your exam, make sure that you draw the diagram and list out the nerves that arise from each cord along with the nerves that arise from the root and the trunk. So we have 2 nerves that arise from the root, 2 nerves that arise from the trunk, and then we also have nerves that arise from the cord of the brachial plexus. So then we have 3 cords, lateral, medial and posterior. Then make sure that you write the clinical correlation, mention about the Erb's point and do draw the diagram for that, and write about the features that are seen in Erb's paralysis: adduction of arm, medial rotation, extension of elbow, pronation of forearm. If possible, do write about the muscles that are involved or muscles that are paralyzed, which causes these typical deformity. So I hope this class was useful for you.